and welcome to Wellness Live. My name is Dr. Olivia Moses, brought to you here at Wellness Live from Loma University Health's Department of Risk Management, the Living Whole Wellness Program. Well, I will be your host today, and we are so excited to have you. And I wanted just to remind all of you viewers, we are called Wellness Live. So if you are viewing us live, you can actually ask questions to our speakers. So go ahead and use the chat box and we can ask our special speaker today any questions that you might have. Well, today is a topic that I am actually very interested in, and many of you are as well. Some of you have worn glasses. Some of you might be interested in eye health and how to get better eyesight. Well, we have a wonderful ophthalmologist here today, and his name is Dr. Ali Mahdavi Fard, and he is a clinical assistant professor here in our ophthalmology department. And he focuses in his area of expertise are cataract, refractive, and cornea surgeries. So he has a wealth of information here today. So without further ado, I'd like to introduce you to Dr. Mahdavi Fard.
Hello, everyone. Thank you. It's a great pleasure to be here, and I thank you for having me here. And I will be happy to share some of them about the refractive surgery, one of the most popular, surgeries in the ophthalmology. Okay, so I'm going to start share my screen. Okay, so first thing that we should know, what is the refractive errors that usually we refer as refractive error? What does it mean? What we are going to treat with refractive surgery? It is one of the most common conditions of the eyes. Actually, it's about 12% of the people worldwide are suffering of some kind of refractive error, and about 4.1% of the population are suffering of vision impairment due to refractive error. And in the United States, more than 150 million people are wearing glasses, some kind of refractive error that are correcting with glass or contact lenses. About 24% of the population of US, or 69 million, it's a big population. The number of people are myopic. It's the most common form of refractive error. It's called nearsightedness. Actually, you need to bring objects closer to have a better view. And estimate about 43 million of these people, this population needs to refract some kind of candidates for refractive surgery. So what are the refractive surgeries? What we really mean by refractive error? Let's go back, take a look at the normal anatomy of the eye. The eye is like a conventional camera. We have optics, we have some lens in front of the eye, they bend, they focus the light on the retina, which looks like a film of the camera. And the normal or emmetropic eye. Emmetropic eye is an eye that without any effort, the light rays coming from the infinity. Actually mean light rays are parallel. They are hitting the eye, they will bend, they will focus on the retina, and will give us a focused and perfect vision. So it's the center of the retina is called fovea. The goal is to focus the light on the fovea, and which is expect to have a 20/20 vision. The main optical system of the eye is the cornea, as a dome-shaped clear tissue just in front of the eye, which is it is main function of the actually refraction or bending the light happens at this level. And another optical system, part of the optical system of the eye is the lens, which is like M&M shaped lens right behind the colored part of the eye, behind the iris. So together, this system are compromise the optical system of the eye. And their goal is, as I said, in a perfect eye is to bend the light rays to focus on the fovea, on the 20/20 center of the vision. But normally in the nature, we don't have an ideal eye. All of the eyes, they have some degrees of refractive errors. One of the most common, actually, forms of the refractive errors is have the myopia, myopic eyes. It's a Greek word. Myopus means someone who is actually squeezes eyelids to see clear. It's an ancient Greek word. So in these myopic eyes, there's an imbalance between the power of the optical system of the eye and the axial length of the eye. So light rays are when, as you see in this picture, parallel light rays when hit the cornea, hit the eye, they are focused somewhere in front of the retina rather than reaching the retina. It means that, for example, or optical system has a high power, or the axial length of the eye is longer than expected necessary for this optical power. Um, and if it is usually referred as axial myopia, means the axial length is longer, is the most common form of this myopia, nearsightedness. This is the most common, actually, form of refractive errors that we see in the people. And it's expected that the prevalence of myopia is increasing worldwide by the time for many reasons, like as more indoor activities, less sun exposure, more close near tasks doing. So the rate of myopia is expected to be higher in the upcoming decade. Another form of refractive error, it's the opposite side, is in fact we have the shorter eye or less power of the optical system of the eye. Light rays cannot bend appropriately, so they will focus behind the eye. So again, we will have a blurred image. The image which is projected on the retina will not be sharp. This is called hyperopia or hypermetropia. And again, as I said, these eyes usually are shorter. It is not as common as myopia, but it still is another problem of the refractive error problems in the population. Another most common form, one of the most common forms, I would say, better word, of the refractive errors is the astigmatism. Again, it's a Greek word, astigmatism and astigmatism. It means that image is blurred and you cannot correct with the regular spherical lenses. It means that the cornea, the optical system of the eye, instead of being like a completely spherical, they have a shape of ovaloid shape. Comparing like imagine a soccer ball and a football. There's different meridians in the football, like more ovaloid. Natural eye, normal in the nature, the structure of the eye is like some kind of ovaloid. It's not complete perfect sphere. So different powers are expected in different meridians of the eye. So it looks like one eye has two powers at the same time, two focal points. One axis is focused, for example, in front of the retina, another one behind the retina. So this is astigmatism, and it is one of the conditions that we try to correct with refractive surgery. So how to correct the refractive errors? And first, how to detect someone has a refractive error, someone that comes in and is complaining of decreased vision. The most common reason for decreased vision, someone complaining of decreased vision, is the refractive error. So if you try to rule it out if we are looking for other reasons. The easiest way to find out if someone has a refractive error is to try the vision with a pinhole. Simply holding a pinhole in front of the eye, if it corrects the vision, it means that the main reason for decreased vision is refractive error, some optical issues. And it can correct up to plus minus 4 digits of the prescription with just a pinhole. For example, if someone has a -3 prescription with holding the pinhole, we expect that vision to improve to 20/20. But it's not like a treatment, it's just more diagnostic. The easiest and the most common way to actually correct the refractive error is the glasses, prescription glasses. They are easy available, they are actually adjustable, they provide some protection on the eyes, and it's not non-invasive. There's no surgery, no procedure for them. Or you can use the contact lenses to correct. It's easier than glasses, but higher risk of infections and more side effects. So if someone cannot tolerate the glasses, for example, for heavy prescriptions, someone has a -11 prescription, will have a very heavy glasses, also magnification effects of them, lenses of the spectacles is a problem. Or someone is an occupational, like athletes, they cannot use the glasses in their job. Or contact lenses for long term, they will have some side effects. For example, they can cause corneal neovascularization, very serious corneal infections. So if someone cannot use any of these non-invasive or less invasive options, it's the time we think about procedures, some permanent treatment for the refractive error. We have refractive procedures done in different levels of the eye. Can be done in the surface of the eye, can be done on the cornea, or can be done inside. So these procedures which are done at the level of cornea are again subdivided into subgroups, incisional and laser assisted. In incisional surgery, actually, it's clear, it's by its name indicates, they're making some incisions on the cornea to correct this irregularity of the cornea, to make the cornea more spherical, or laser assisted to change the shape of cornea, reshape the cornea to the power of the lens that we need for the axial length of the eye. One of the most well-known of the incisional surgeries was radial keratotomy, RK. It developed in about 1970s. Initially, it was looking a wonderful procedure. Just in a few minutes, you could fix all your refractive errors immediately. It was made by making some radial incisions, deep incisions on the thickness of cornea, as you see in the picture here. Depending on the prescription, maybe 16, maybe 4, maybe 8, depending on the prescription number of these incisions used to be different. Initially, the results were good, but later they found that this is extremely weakening the cornea. Result ends up after years of irregular corneas and some optical issues like seeing halos, glares, and gradually tend to be switched to hyperopia. So now it is not a very common surgery, almost abandoned completely and replaced by the most modern and safer and more predictable surgeries, which are done with the laser or so-called photoablative procedures. The photoablation actually means that we are employing laser beam, a laser light, like photons, high energy photons, to change the shape of cornea, reshape the cornea. And we usually use excimer laser. It's abbreviated form of excited dimer because two actually molecules are usually excited by the electrical shock to emit the electric photons, high energy photons, and then we can direct them to the surface of cornea to some kind of evaporate the cornea. And its energy level is so finely tuned that it just breaks the carbon-carbon to carbon-nitrogen bonds without making extra heat. So we don't have a thermal damage to the cornea. We just breaks the molecules like the cold evaporation of the tissue. And when it is a fine-tuned, it can change the shape of cornea, reshape the cornea without further damage to the cornea. One of the most common, the first generation, and still one of the most popular common forms of doing the refractive surgeries is the photorefractive keratectomy, or PRK. It is, as I said, it's the first generation, but it's still one of the most popular techniques to do this. It is done in the surface of the cornea. It is just like as you see in this schematic photo picture. First eye is numbed, anesthetized, then surface epithelium. Epithelium is the most superficial layer of the cornea, which provides a very strong mechanical barrier to the cornea. So it is removed by the means of some like chemicals, like 20% alcohol, or mechanically removed and exposes the cornea, the stroma, the body of the cornea. And the laser beam is then radiated, is emitted on the cornea, change the shape as expected, and then a contact lens is placed. And usually epithelium heals in a matter of few days. Usually 2 to 5 days will take this epithelium to heal, and the surface of the cornea will be protected again. So it has a big advantages. It's a very quick surgery. It takes just a few minutes without further cutting or manipulating of the tissues. And there's no corneal flap, which you will see in the LASIK surgery. We make flaps. The PRK doesn't need to make a flap, which means that it's weakening of the cornea. In the PRK, there is no weakening of the cornea because no collagen fibers, the cornea are severed. So it is a safe at this regard. And also in thin corneas, when we cannot do other laser-assisted surgeries that I'm going to talk about LASIK, you will see that it's not a good case for corneal thin corneas. For some of the thin corneas, PRK can be done easily without any complications. But it does have its downsides, like a more patient discomfort because the epithelium is removed. Expected that for the first couple of days, you have some pain, some light sensitivity. Also, recovery times are longer because the surface after healing takes a few weeks, about 6 weeks for the epithelium cells to remodel the surface of the cornea to smoothen, to provide a smooth and perfect optical surface. So we have to wait about 4 to 6 weeks for the patient to reach the optimal vision. And also for high prescriptions, about more than 4, there's a risk of haze development because of this. Depth of ablation triggers the cells in the cornea, and they will make the cornea hazy. Now we implement some medication like mitomycin C, the rate of haze development is decreased, but it still is a significant risk for patients undergoing PRK. And glare and halos, which is something common we expect with any kind of maybe refractive surgery. So on top of PRK, another actually procedure developed, which looks like it's some advantages over the PRK. It's called laser inside the keratinometers, or LASIK. It is the most common, most popular refractive procedure worldwide. And it is because its popularity stems from very quickly you will feel the difference. It is painless, very short, in a matter of just few minutes to hours of the recovery time. Immediately you will feel the difference. You will feel that your vision is corrected without glasses, without any correction. You have a perfect vision immediately after the surgery. And because it's not actually doing anything with the surface of the eye, so it's not painful. There's not like a scratch on the surface of it. And it is done, I have it in this short video. It is first a flap is made. As you see in this video, we use another type of laser. It's called femtosecond laser. In the past, we used to make this flap by a microcraton with a blade. But now with a new generation of laser, the flap is made, is folded one side and through the hinge, and the stroma, the bed of the cornea, which is exposed, is ablated by the laser, the same excimer laser we use in PRK, and the flap is returned in place. And because there's no scratch on the surface of the eye, there's no pain, no discomfort, and there's no need for the epithelium to remodeling. So we expect an immediate and very quick recovery. It is the most popular and the most common refractive surgery we do. So as I said, it is a very stable and very good procedure, but it does have, again, some disadvantages. Thin corneas, because of this making this flap, further weakening of the cornea, thin corneas beyond this certain level are not good candidates. So we needed some cornea structure to be strong enough to tolerate the flap making and ablation, removing of the tissue. So we will always have the flap issues. The cornea is a tissue that is not healed by scar formation, by fibrosis. So this flap is a lifetime risk of, is prone to detachment. If someone is, for example, athlete going for some confrontational sports or has exposed to trauma, has the lifetime risk of this flap to be detached, dislodged, and cause a serious, actually, vision problem. But overall, it's a very safe process and with a very short recovery time. And in a good selected candidates, it's a perfect surgery. For now, if we're looking at those previous surgeries, PRK and LASIK, PRK has longer recovery time, more pain, but safer, less weakening of the cornea, but LASIK, more weakening of the cornea, but instead less pain and shorter recovery. Another procedure has been invented. It's called SMILE, small incision lenticle extraction. It's very modern surgery. And in the surgery, instead of excimer laser, instead of actually evaporating the tissue, we use the same, the femtosecond laser. It's a different type of laser, actually. With this laser, we can make a cut through the clear tissues and the thickness of the tissue without actually opening the tissue. Like this is in the video you can see. Femtosecond laser makes a cut in the thickness of the cornea. Like, look, imagine we are removing a lens from the thickness of the cornea. So we change the shape of the cornea, we adjust the power of the cornea without actually removing, weakening of the front part of the cornea. The lenticle is made in the thickness of the cornea and then is removed, pulled out through a small incision, and that's it. So no weakening of the cornea, immediate recovery, immediate improvement of the vision, and no pain, no discomfort, and very little risk of infection compared to PRK, and no risk of haze. So this is another, is gaining popularity more and more as a refractive surgery. As I said, advantages definitely are clearly has many advantages on the conventional laser-assisted surgeries, but disadvantage is technically more demanding. It has a very sharp learning curve for the surgeons and needs a some good experience in the laser refractive surgeries that to be able to do a safe smile surgery. And also, it has some more limitations than LASIK for higher prescriptions. There's a procedure, it's called conductive keratoplasty. This is mostly for the hyperopic or far-sighted eyes, or some of the presbyopic eyes. Which is using some kind of thermal changes happening in the thickness of cornea, shrinking of the tissue to make change the shape of cornea to make it more steeper, more powerful lens. But because it's not very stable, it's not a very common procedure. Just I want to talk about it just quickly to show that it's another procedure that sometimes is employed, but the basic, the most common and popular are the laser-assisted surgery. So what if someone is wants to undergo a refractive surgery, but is not a candidate for laser vision correction? For example, they have a thin cornea, or they have a very high prescriptions. We have the main limitation of laser-assisted refractive surgeries is the corneal thickness. If you have a thin cornea, if we have a higher prescription, for example, -12, -15, -11, for an average cornea will not be doable to do a laser assisted. We cannot ablate the cornea too much to weaken the cornea because of to correct this prescription. So there are other group of surgeries, the intraocular surgeries. They are actually done through an incision. We make an incision in the eye. We go inside the eye and change the optical system of the eye from inside. We have two types of lenses actually designed for this purpose, like ICL, as you see on the left side, or in front of the color part of the eye, like iris claw, iris fixated IOLs. These are the intraocular lenses that looks like we are implanting your glasses, your contact lens inside your eye. In some group, they're implanted behind the color part of the eye. In some group, they are implanted in front of the color part of the eye. They are proven that they are very safe procedures and very stable conditions, stable actually outcomes for the people who has a high prescription, not good candidate for laser-assisted vision correction. And this can be another option for these people. But they have the risks of intraocular surgery, more risk of infection, more risk of intraocular problems like retinal detachment compared to more superficial surgeries like a laser surgery. But this can be another option. Another intraocular option can be, which is now getting more popularity, is the refractive lens exchange. Just like cataract surgery, we can remove your natural lens and replace it with a right power artificial lens. So especially with the modern and the most recent, very modern design of the lenses, this cataract surgery now has been switched as just removing the cloudy lens to a refractive procedure, refractive cataract surgery. So just like similar to cataract surgery, we remove the lens, and the lens that we are implanting instead of this natural crystalline lens, we can adjust the power, we can correct the astigmatism, and even with the new generation multifocal premium lenses, we can correct the presbyopia as well. Actually, trying to make you completely independent of glasses, give you far and near vision. But again, this surgery does have its own limitations and disadvantages. Intraocular surgery, it is not going to be as perfect as a natural eye. So especially multifocal lenses, some people report halos and some people are not happy with that. So overall, it does have its actually advantages and disadvantages, but it's another good option, especially for the ages beyond the middle-aged people who are expected to develop cataract in the upcoming years. It can be a very good option to do a cataract surgery and implant the right power lens and to correct any refractive errors. So that's the first part of my talk, and I'm going to stop sharing the slides for now. And any questions?
Yes, thank you, Dr. Mahdavi Fard. We do have some questions coming in. Just want to remind our online audience, if you're watching us live, to go ahead and type in your questions. The first question I'm going to ask you that has come through is, how long do the results of refractive surgery typically last?
Yeah, it depends on the age and depends on what type of surgery is done. Usually, it is expected that the results to be permanent. but it is not always happening. Sometimes remodeling, for example, for high prescriptions done in a PRK, remodeling of the surface of the eye epithelium will change some of the outcome. Or the females are get pregnant or nursing, we expect some changes in the tissue can happen, and again will make the results of unpredictable. And we expect that some regression, it's called regression actually, recurrence of the prescription after a while. For the lens surgery, like a cataract for refractive lens exchange cataract surgery, results are more stable. More actually, we expect that for almost a permanent correction of the major part of the prescription.
Is there an age limit? That's another question that we had. When can you get this surgery? When is ideal?
Yeah, it's not going to be the second part of my talk about who is a good candidate. Yeah, definitely we have age limit for not too young, not too old. And it is important. Age selection is one of the main criteria for deciding a candidate, someone for a refractive surgery, definitely.
Okay. When you're thinking about getting these surgeries, when is it time to start talking to an ophthalmologist?
Yeah, as I said, glasses are the safest way, most recommended, I think, way to correct the prescription. So it's some personal decision. If someone, as I said, the job, they occupationally cannot use the glasses, and really at some point that maybe lose some people can lose their job or cannot apply for a certain job because of their prescription. So yeah, it's time to talk about refractive surgery. Or someone is dependent on contact lenses. In the long term, contact lenses have more complications, more side effects than refractive surgery. Some people are using contact lenses for years. Their cornea will start get vascularized because it looks like the cornea is hypoxic, cannot breathe. So will start growing unusual vessels on the cornea. Also, long-term contact lens use can damage stem cells, the maintenance cells which reside on the periphery of the cornea. So it makes the cornea prone to ulcers, non-healing ulcers, infections. So if someone is really dependent on the contact lenses and cannot go back to glasses and or maybe uh, does not tend to go back to glasses. Again, these actually they are good candidates to think about refractive surgery.
And let's get to one more question. Are there any specific precautions or guidelines individuals should follow in terms of sun exposure and outdoor activities post refractive surgery?
Yes, after especially PRK, it is recommended that to avoid sun bright light for just a few, maybe weeks, because UV light exposure can make this development of haze a little bit to make it more common. So, but after LASIK, usually it is not the problem. After a smile, it's not the problem. After cataract surgery, again, it's not unless we use a light adjustable lenses. There are some special lenses that after implantation, they are sensitive to light, we adjust the power. Otherwise, there's not a special limitation.
Okay. Well, thank you. We are actually running out of time, so we have about 5 minutes. Can we do a fast pass at the second half of your presentation?
Yes, of course, very quickly. So the question was, who is a good candidate for refractive surgery? Stay suitable prescription, not too high, not too small. We don't want to unnecessary surgery on the most necessary tissue organ of the body. For example, someone has a very small half diopter nearsightedness is not good candidate for refractive surgery. If someone has a high prescription -12 is not good candidate for laser surgery. So will be candidate for example, intraocular lens refractive procedure. Is your prescription stable? It should be stable at least for a year or two. Then we can decide on a refractive surgery. We don't want to do the surgery now, and next year, again, regression, recurrence of the prescription, we have to do another surgery. Repeat surgeries have more side effects, so more complications. So we expect a reasonable power prescription stable for a while. And if someone has other serious eye problem like glaucoma, like retinal macular degeneration, like lazy eye, amblyopia, any other problem, dry eye, severe dry eye, or autoimmune diseases like collagen vascular disease. Again, these people are not a good candidate for refractive surgery. Again, this is your answer your question. Not too young. Usually I personally prefer not to do refractive surgery under age 20, 22, because still the eyes in evolution, it's growing. Or not too old. Too old people maybe benefit on the cataract surgery, intraocular surgery, rather than doing the LASIK surgery. And as I said, the corneal thickness is a limiting factor. A thick cornea or diseased cornea will not be a good candidate for special type like laser-assisted vision corrections. Realistic expectations, the surgery has its own actual limitations. Someone who's expecting to have a supervision, 100% guaranteed, no, it is not going to be a good candidate for refractive surgery. We are trying to just limit, decrease your dependency on glasses. It's not 100% independent of glasses with a 20/15 vision. You should understand the limitations before deciding on the surgery. Good general health definitely is a factor, and not pregnant or nursing, because as I said, there are some hormonal changes will cause the cornea to be unstable, refraction, prescription unstable. So we have to wait a while, at least 6 months to 1 year after pregnancy or nursing, to decide on a refractive surgery. Stable lifestyle definitely is a factor. Avoid the limitations that are necessary after the surgery. And this is almost a brief review of the refractive surgery, and very quick, just the very basics of the refractive surgery.
Thank you, Dr. Mahdavi Fard. This presentation has been hugely informative for all of us. Maybe we can end with one question. And the question is, how does someone, if someone is interested in getting some type of refractive surgery, what should they look for in a surgeon or an eye center?
Yes, I think first thing, if someone decides to think about refractive surgery, to see an optometry doctor, to check their prescription, to see how is their prescription stable, is their prescription with a reasonable range for a refractive surgery, and also they will do a comprehensive eye exam for them. So if they don't have any other eye problem, if someone has a glaucoma, retinal macular disease, definitely they will not be a good candidate. So I think the first step will be to consult an optometrist doctor and to check the prescription and have a general eye health exam.
And then, are there different standards that they should look for in a clinic that, kind of a seal of approval or licensure or anything like that, that they should make sure that their clinic has?
Yeah, definitely. Um, Refractive surgery centers need some standards. They actually have the most recent updated actual platform for the laser machines, because they're updated very quickly, and the more recent they have a more safer actually profile. I think it's one of the major factors. Also, experience of the surgeon, especially in smile surgeries, another factor that maybe you can look at it. These are actually the main things that you should think before selecting which center you want to go to site to your surgery.
Okay, well, thank you so much, Dr. Mahdavi Fard, for sharing your expertise with us and being here with us today. And I want to thank all of you, our viewers, for joining us today. I hope this has been extremely informative for you. And if you are wanting to move forward with any type of refractive eye surgery, and I also want to invite you to our next session, which will be May 30. And if you are a person or know of a person who deals with allergies and kind of an immunology response, or your immune system is responding to the environment, it'll be a perfect presentation for you, as Dr. Louis Saka will be our guest speaker. Again, thank you so much for joining us. My name is Dr. Olivia Moses.